afternoon, everyone. I would like to take a moment to introduce our esteemed mentor for today's case presentation on gestational diabetes mellitus. Dr. Rupakala ma'am is not only a highly respected senior in our department, but also dedicated expert with extensive experience in obstetric field. Their guidance and insights are invaluable to us, and we are truly fortunate to have their support as we dive into this case. Please join me in welcoming Dr. Rupakala ma'am to the session.
Yeah, thank you, Dr. Divya. We now start with the case discussion. The 9th-term student elavarsan is going to present the case now. Over to you, elavarsan. Start the case.
So demographic details: a patient named Mrs. A.B.C., who is of 25 years of age, residing in Kengeri, who is a housewife by occupation, who has studied till 12th standard, belonging to the lower middle class according to the modified Kupusomi classification, came to the hospital on 22nd October 2024 and was examined on 23rd October 2024. Her LMP was 20th April 24 and her estimated date was 27/1/25. She is a primary gravida of gestational age 26 plus 4 weeks. Her husband's name was Mr. XYZ, who was 29 years of age and was a cab driver by occupation.
Okay, elavarsan, in this slide, whatever you put up the demographic details, is there anything which is important?
Yes, from the age of the patient is important.
Yeah, how?
Because in an elderly case, there can be increased risk of abortion, preeclampsia, chronic hypertension, gestational diabetes mellitus, then fibroids.
Usually common medical disorders like preeclampsia, and in particular, since we're discussing the case on GDM, they're more prone to occur after the age of 35 years. And anything else other than the age, which is important here? Ethnicity. GDM or diabetes is more common in the Southeast Asian population, especially among the Caucasians, isn't it? So ethnicity, Southeast Asia is more common. So that is also important in this demographic details. Yeah, continue.
So chief complaints: primary gravida at 6 months of amenorrhea, came for a regular antenatal checkup and was found to have high blood sugar levels on evaluation.
So what are the different tests you use to evaluate the GDM? What are the different screening tests? You said she's admitted for evaluation. So what are the screening tests you do to evaluate a GDM patient?
In India, in our hospital, we follow DIPSI guidelines, ma'am.
Okay.
So it's a single-step procedure which is done at first. So screening is done at the first visit at 24 to 28 weeks and 32 to 34 weeks. In this, 75 grams of glucose is given in 300 ml of water, and she has to drink it over 5 to 10 minutes. And 2-hour postprandial blood sugar levels is checked. And for this test, she did not need to fast. So if the blood sugar is less than 120, it is normal. If it's between 120 to 140, she is decreased gestational glucose tolerance. And 140 to 200, she's a case of GDM. And more than 200, she's a case of overt diabetes mellitus.
What is the type of screening you do for GDM? I meant, is it a selective screening, a universal screening?
No, universal screening, universal screening.
Yeah, because India is a moderate risk for diabetes. It is in the moderate risk. If it is a low risk, then you need not screen the patient, you do a selective screening. But since India is at the moderate risk for GDM, you have to use universal screening. Suppose a high-risk patient, then you need not do screening of the patient. You directly have to go ahead and do the diagnostic test. Okay? So, mild, moderate, severe, it depends on the low risk, moderate risk, or high risk. Low risk, you can do only selective screening. Moderate risk, India is at a moderate risk, so you have to do universal screening. And those patients who are at high risk, you can directly, instead of screening, you have to directly go for diagnostic tests. So what are the other 1-step and 2 steps method of screening for GDM? Can you enumerate the other tests? What you said is the DIPSI guidelines, that is the Government of India and the FOXI recommend single step method, that is irrespective of the fasting status of the lady and irrespective of any diet what she has taken in the previous 3 days. You're supposed to give a 75 gram of loading dose of glucose. You dilute in 250 to 300 ml of water and allow her to drink between 5 to 10 minutes and do a 2-hour PPBS. And if it is between 126 to 139, you call it as impaired glucose tolerance. Between 140 to 200, it is GDM, and above 200, you diagnose it as overt diabetes. That is DIPSI test, one-step method. What are the other steps?
So two-step procedure.
And also the tolerance test. Can you enumerate the other tests?
Sure. So the OGCT test, according to ACOG, so 50 grams and 300 ml of water, and we check 1 hour ppbs, and if it's more than 140 milligrams per deciliter, then we go for the second step, that is the OGTT, where the patient is asked for overnight fasting and 3 days of normal diet and exercise before the test, and she's given 100 grams of glucose and 300 ml of water, and 4 blood samples are taken. The fasting blood sugar 1 hour, 2 hour, 3 hour ppbs. So according to the NDDG criteria,
yeah. Carpenter and Coston's ACOG regime. That is, you give 50 gram of glucose, you dilute in 500 ml of, 250 or 300 ml of water, and then you take 1 hour fasting, 1 hour, 2 hour, and 3 hour. Fasting should be 95, 1 hour should be 180 milligram, 2 hours should be 155, and 3 hours should be 140 milligram per deciliter. That is the primary ACOG recommendation. What is the NDDG criteria? That is for ACOG alternative test.
That is, the MBBS is to be more than 105, or 1 hour should be more than 190, or 2 hours is more than 165, or 3 hours more than 145. Any two values is positive, then we consider.
Yes. One is the Carpenter-Coston's regime, which is primary, as you told. The other one is the NDDG criteria. Can you tell me the indications for doing GTT?
GTT, when the OGCT test is more than 140 milligram per deciliter in the 1 hour ppbs.
See, Government of India does not recommend that. DIPSI and Government of India or FOXY recommends only 75 gram of glucose, which is loading. That is, you do at the first visit. Okay, if it is negative, you repeat at 24 to 28 weeks. Then if that is negative, you continue it as normal pregnancy. If it is positive, you treat as GDM and you repeat the test at 32 to 34 weeks. If it is negative, then you continue it as normal pregnancy, right? This is what you do in step method, irrespective of what is she has taken for the past 3 days, irrespective of the fasting status, you have to do this test. What about IIDPG-SG, International Association of Diabetics and Pregnancy Study Group?
In this, we give 75 grams of glucose in 300 ml of water, and 3 blood samples are taken. So it is fasting blood sugar and 1 hour and 2 hour ppbs.
Correct.
And so the values are fasting blood sugar should be more than or equal to 92, or 1 hour should be more than or equal to 180, and 2 hours is more than or equal to 153. Then we diagnose it as GDM case.
Yeah, correct. 75 gram of glucose load. Usually this test is done between 24 to 28 weeks, 3 days of normal diet, overnight fasting. FBS should be 92, ppbs 1 hour is 180, and 2 hour ppbs should be 153. And this GTT is indicated whenever there is OGCT is abnormal, you allow them to do GTT. Otherwise, as I told, direct indication for GTT in the first trimester is whenever there is an elderly primate, when there is a family history of diabetes, obese women, unexplained maternal weight gain, or a past history of macrosomia, a past history of GDM in the previous pregnancy, or a history of congenital anomalies in the past pregnancy, past history of PCOS, unexplained IUD at term, recurrent pregnancy loss, and recurrent candidal or candidal infections during the present pregnancy or the previous pregnancy are all indicative to do GTT at the first visit instead of doing a screening test. Directly, these are the indications for you to do GTT. So what we follow in the screening test is a DIPSI, Government of India module or the FOXY module with 75 gram of glucose. So in the first trimester, okay, go on, continue with your presentation.
So history of presenting illness, Raimi Gravida, gestation age of 6 months of amenorrhea, came for her regular antenatal checkup and was found to have high blood sugar levels on OGCT. She is not a known case of diabetes mellitus, no history of polyphagia, polydipsia, increased frequency of or burning micturition, leak or bleeding PV, pedal edema, epigastric pain, sudden weight gain, blurring of vision, bowel and bladder disturbances. She is appreciating fetal movements well.
Why is it you have asked about the sudden weight gain, blurring of vision, pedal edema, epigastric pain? Why
so, mom, to rule out preeclampsia.
Yeah, associated
pregnancy disorder. Yes.
Yeah, preeclampsia and GDM usually coexist. So that is why you will have to, about 1 to 3% of the cases of GDM usually have preeclampsia, So you're right in asking these questions that the patient does not have any premonitory symptoms of preeclampsia. Okay, then go ahead.
History of present pregnancy, marital history, married at 24 years of age, 1 year of active married life, non-consanguineous marriage, first trimester, spontaneous consumption after 1 year of marriage. She's a booked case, and UPT was done at 2 months of amenorrhea and was found positive. Routine investigations was done and were normal. Blood grouping was found to be her blood group was found to be B positive. Dating scan was done at 8 weeks and found to be normal. Double marker test was not done. No history of fever with rash, burning micturition, drug intake, excessive vomiting, bleeding or leak PV. No exposure to radiation. NT scan was done at 13 weeks and was normal. Folic acid supplementation was taken from first visit.
So this is first visit. So what are the tests you do in the first visit? Whenever you're suspecting GDM, what are the investigations you do other than OGCT? OGCT is indicated at the first visit itself, isn't it?
Yes, sir.
Okay. Other than OGCT, what are the other tests you can do to diagnose GDM?
HbA1c should be done in the first visit.
Yes. Fasting also you can do. Normally it should be 95 to 100 milligram. Yes. Then
the routine urine investigation and culture.
No. What hemoglobin A1c should be how much?
HbA1c should be less than 6.5. More than 6.5 is over this.
Okay. So fasting, postprandial, hemoglobin A1c and OGCT at the first visit all should be done to diagnose GDM. You said routine investigations have been done. What are the routine investigations in pregnancy?
So hemoglobin levels, RBC and WBC levels are differential leukocyte count. Then albumin and urine culture, then urine investigation, then serology such as HIV and HBsAg.
So WHO recommends hemoglobin, blood grouping, RH typing, VDRL, HIV 1 and 2, HBsAg, complete urine examination, then OGCT in the first visit. How about the thyroid profile?
Thyroid is not recommended, but we still do now.
It is not recommended as a routine by WHO, but the Endocrine Society of India recommends thyroid screening also in the first trimester. Whereas the ACOG recommends, in addition to all this, the urine culture sensitivity, cervical cytology, screening for even sickle cells and thalassemia are also recommended by ACOG, and RCOG also recommends cervical cytology screening. Otherwise, WHO recommends only the basic screening, thyroid, cervical cytology, others only by particular guidelines, that is ACOG, RCOG. WHO, these are the only routine investigation. Okay, next.
The second trimester, quickening was felt at 5 months of amenorrhea and continued to persist fetal movements well. 2 doses of TD vaccine taken. Anomaly scan done at 20 plus 2 weeks and was found to be normal. OGCT was done at 26 weeks, 2 days, and PPBS was found to be 160 mg per deciliter. No history of headache, excessive agent, blurring of vision, epigastric pain, field edema, and excessive thirst. No history of leak of BPV. Iron and calcium tablets were taken.
Okay, what is the importance of quickening?
Quickening, it helps us to because quickening in a primary gravida is felt at 16 to 18 weeks, and in a multigravida is felt at primary gravida at 18 to 20 weeks, and in a multigravida 16 to 18 weeks. So from this we can calculate the estimated delivery date.
Yeah, very good. It is the perception of the fetal movement by the mother for the first time. You call it as quickening. It whenever there is a quickening, it is reassuring to the mother that the fetus is healthy, and you can also calculate, as you said, depending on the primary or multi, you add 20 or 22 weeks, depending on primary gravida or multigravida, and approximately you get the expected date of delivery. Okay. Continue.
So menstrual history, menarche at 13 years, regular cycles, 28-day cycle with menstrual flow lasting for 4 to 5 days and 3 pads per day, not associated with dysphoria or clots. Her LMP is 24-24.
And you should also mention whether the periods were regular or irregular, and if irregular, how long it used to be prolonged. Okay?
Okay.
Once in 30 days or 60 days. If it is regular, you mention it is regular.
Okay. So past history.
Yeah, past history.
There's no history of diabetes mellitus, hypertension, tuberculosis, asthma, thyroid disorders. No history of blood transfusion. No history of previous hospital admission. No history of surgeries. Our family history, our mother is a known case of diabetes for 6 years and is on regular medication.
Okay. In the past history, since your case is primary gravida, so there's no question of that she had any past history of any GDM. But if at all there is any past history of GDM, then you have to go into the details of previous medication, whether she was on MNT, oral hypoglycemics, or on insulin, and if so, what was the outcome, at what period of gestation was it terminated. So it gives you an idea for the management in the present pregnancy. Since your case is primary gravida, you need not ask this, but you keep in mind this is past history is very, very important, as well as the family history in the mother, father, siblings, uncle, aunt, and grandparents. All this history must be taken in case of GDM patient, diabetic patients. Okay?
Okay.
Elavarsan, is it okay?
Yes, sir. Yes, sir.
Yeah,
Yes, ma'am. Yes, ma'am.
mother, siblings, uncle, aunt, and grandparents.
Okay.
Continue.
So personal history, she is on mixed diet. She takes two idlis and 1 cup sambar, 1 cup coffee for the morning breakfast, and 3 cups of rice and 2 cups sambar in the afternoon, and 1 apple and 1 cup milk in the evening. And night she takes 3 cups of rice and 2 cups of sambar. The calories required are 2,500 kilocalories, and the calorie intake is 2,100 kilocalories. So there's a calorie deficit of 18%. Normal appetite and adequate sleep, regular bowel and bladder movements, no history of substance abuse or drug allergy.
So deficit, what do you comment on this? The calorie intake.
So it is
2,200. So you add up 300 for the present pregnancy, isn't it? So you add calories for the pregnant woman. So there is a deficit here, isn't it?
yes.
So you'll have to ask the details and then advise her regarding the proper caloric intake.
Yes.
All right?
Yes, sir.
Excellent.
So general physical examination. The general condition of the patient is good. Patient is moderately built and moderately nourished. She is well oriented to time, place, and person. Patient was examined under adequate light after taking consent. Vitals, patient is afebrile. Her pulse rate is 80 beats per minute, regular rate, rhythm, volume, character, and no radio radial delay or no radio femoral delay. Her BP was 130 by 74 mmHg in the right arm and was examined in sitting position. Respiratory rate was 16 cycles per minute. Pallor, eclipse, cyanosis, clubbing, lymphadenopathy, and edema was absent. Her height was 165 centimeter. Her pre-pregnancy weight was 68 kgs, and BMI is 24.98 kg per meter square. A breast, spine, thyroid examination found to be normal.
So can you elaborate on how did you record the blood pressure?
And the patient was in a sitting position. The cuff was tied to her right arm, and the BP was taken.
You have to ask the patient to rest for 5 to 10 minutes.
Awesome.
For the BP immediately as she enters the OPD. So ask her to rest for about 5 to 10 minutes. You have to record the BP in a sitting position or with a 45-degree tilt with her legs supported. So avoid the supine position, and the arm also should be well supported. You measure the BP on the first visit on both the arms. So this excludes any of your vascular disorders when there is a radiofemoral delay. The cuff length should be 1.5 times more than the circumference of the arm, and the width should be enough to cover at least 2/3 of the upper arm. And the standard size of the cup usually is between 13 and 22 centimeters. And in labor, how do you record the blood pressure? Normally, in antenatal patient, you record them in the sitting position. If the patient labor, you record it in the left recumbent position. Is that clear? So,
yes, sir.
So do not record the blood pressure immediately as she enters to the OPD. Ask her to rest for 10 minutes and then record the blood pressure.
Okay.
And also the pre-pregnancy weight here is 68 kg. Why is it you want to know the pre-pregnancy weight?
Because calorie requirement calculation is based on the pre-pregnancy weight, and even if there's any anemia, then the formulas of pre-pregnancy weight to calculate the elemental iron requirement.
Yeah, one is you require this pre-pregnancy weight or weight during the first visit to calculate your BMI, right? And also, if the patient's pre-pregnancy weight is more than 90 kg, or if the BMI is more than 30, they're more likely or more prone for the development of GDM. So you have to be careful in such patients where the pre-pregnancy weight is more than 90 kg or where the BMI is more than 30 kg per meter square. Okay?
Okay.
Yeah, continue.
Systemic examination, CVS, S1, S2 heard, no added sounds. Respiratory system, normal vesicular breathing sounds. CNS, IM mental functions are entered. No focal neurological deficit seen. For abdominal examination, inspection, the shape is globular and distended. All the quadrants move equally with respiration. Umbilicus is central and inverted. Linear nigra and stria gravidarum are present. No stars, sinuses, dilated veins are seen. Earlier orifices are intact.
So you have written here globular and distended, right?
Yes, ma'am.
Globular and distended. Suppose it is over distended. How will you identify that there is over distension of the uterus?
The flanks will be.
Yeah, correct. The flanks will be full and the uterus, the uterine fundus will be at the level of Ziphistern. So whenever
Yes,
over distension, what is the idea you get?
it's either polyhydramnios or there's multiple pregnancy.
Yes, it could be multiple pregnancy, it could be polyhydramnios, or in particular pertaining to GDM, it could even be macrosomia.
Yes.
So over distension, flanks will be full and the uterine height will extend up to the level of the Ziphistern. Okay. So what importance you have written about? No, inspection. Okay, go ahead, continue.
So palpation, the fundal height corresponds to 26 to 28 weeks of gestation. The symphysis of fundal height is 26 centimeters. Fetal parts are palpable and external development present.
Okay, what is the importance? Why is it you have measured the symphysis of fundal height? What is the importance of measuring this? And how do you measure?
Symphysis of fundal height, first is check the fundal height. You see the first with ulnar border, you see where the resistance giveaway is felt. Then from there, we put the patient in the supine position. Then for checking the fundal height, you need to flex the hip, but flex the legs. But when checking the symphysis of fundal height, as a patient extend the legs, and from there you measure from the point of the upper fundus of the uterus to the pubic symphysis. This gives us the symphysis of fundal height.
Yeah, that is from the fix. First is you find out, you mark where is your fundal height, the maximum position, you mark it with a pencil. Then the fixed point is the symphysis pubis. Take a measuring type in centimeters. You measure from the symphysis pubis to the uppermost part of the uterus. So you measure it in centimeters and that gives you the value of symphysiofundal height. It corresponds to the gestational age between 24 to 36 weeks. Okay. So indirectly it gives you an idea of what is the period of gestation. So 24 centimeters means 24 weeks. If it is 34, the symphysiofundal height will be 34 centimeters. So the only problem is this symphysiofundal height does not correspond from 24 to 36 weeks in case of multiple pregnancy or in case of polyhydramnios. Usually, how much does it increase?
1 centimeter per week. One centimeter per week.
And that, you remember, is only after 20 weeks. So after 24 weeks. So before 24 weeks, it does not correspond, nor does it increase. So symphysiofundal height increases by 1 centimeter per gestational week, and it corresponds between 24 to 36 weeks of. Is there any other importance of measuring just the symphysiofundal height? Anything else you can? It is important.
We can calculate the estimated fetal weight using Johnson's formula.
You can calculate by Johnson's formula by measuring the symphysiofundal height minus 11 or 12, depending on whether the head is engaged or not, and you multiply by 155, it will give you the weight in grams. Very good. And you have forgotten to mention here the waist circumference. You must also measure the waist circumference around the umbilicus, in the abdomen at the level of the umbilicus, also called circumference. The normal abdominal circumference is about 95 to 100 centimeters at term. It increases by about 2.5 centimeters or 1 inch per week after 30 weeks. So if the girth is more than 100 centimeters, it indicates that the uterus is over distended. Okay?
Okay.
I've already told you will indicate clinically by the flanks being full and the uterine height being at the Ziphisternum. So this measurement of abdominal girth is important only after 30 weeks of gestation and not before.
Okay.
Normally, 55 to 100, anything more than 100 indicates there is overdistension, which could be because of polyhydramnios, multiple pregnancy, or even the macrosomia. So you measure only the abdominal circumference after 30 weeks. Okay, continue.
Okay. So auscultation, fetal heart rate of 144 beats per minute, regular, hard on the left quadrant. Then summary, a 25-year-old booked primary gravida at 26 plus 4 weeks of
Go to
gestation.
the previous slide. Go back to the previous
Yes,
slide.
ma'am. Yes, ma'am.
Fetal heart you have written. Where is it? In which quadrant?
It was heard in the left quadrant.
Left quadrant. Suppose it was in the right quadrant.
Yes, ma'am.
It can be in the right quadrant, right? So if it is
Yes,
in the
ma'am.
it indicates to you that it could be the third position, that is the right occipital posterior, right?
Yes.
That is
Yes.
why you need to know which side is the back, whether it is on the left side or the right side. Right side, it gives you an idea, subumbilical flattening with the fetal heart being on the right side, possibility of right occipital posterior to be considered. And you also written 144 beats per minute regular.
Yes.
Can you comment on this?
Ma'am, usually the fetal heart rate is from 100 to 160 is considered as normal heart rate. Anything less is known as bradycardia, more is tachycardia.
No, you said you have written regular. Good. Normally, it is usually regular. Very rarely, the fetal heart can also be irregular. Where is it irregular? Or in cases of congenital heart disease, you do get the fetal heart to be irregular. It's very good that you commented 144 beats per minute and regular. Okay? Very rarely, it can be irregular in case of arrhythmias or a congenital heart disease. Okay? Summarize the case.
So summary, a 25-year-old booked primary gravida at 26 plus 4 weeks of gestation was found to have high blood sugar levels on OGCT and was admitted for sugar monitoring. Obstetric examination revealed a singleton live fetus with uterus corresponding to 26 weeks of gestation, and fetal heart rate is 144 beats per minute, regular and heard on the left quadrant. She has normal findings on obstetric ultrasound scans and is able to perceive fetal movements well.
Okay. In the palpation, you have not mentioned anything about the grips.
Because this is 26 weeks of gestation now, so the grips are not done. It's decided from 28 weeks of gestation.
Very good. All the Leupold's maneuver or grips should be done only after 28 weeks. So before that, and these grips will give you an idea about the lie or presentation of the fetus and also for the management in labor. So before that, you will have to mention only about the presence of the fetal part and external ballotment. These two things, fetal parts are felt and external ballotment is felt. These two things are important. Okay? Here somebody include the age of the patient, okay, obstetric history, period of gestation, presentation, and complication. In this particular case, she is on GDM, whether she is on MNT, oral hypoglycemics, or insulin. All positive history findings as well as positive examination findings should be included in your summary of the case. Okay. The diagnosis.
So provisional diagnosis: a 25-year-old primary gravida, 26 and 4 days of gestation with gestational diabetes mellitus.
Okay, with no other complications, right?
Okay. Oh, yes, sir.
On what? That's what I said.
She's on MNT.
If the patient is on GDM, you need to mention whether she is on MNT, whether she is on oral hypoglycemic or on insulin. You will have to mention.
Okay.
Now she is on
MNT.
MNT. Okay. Okay. You should include that in your provisional diagnosis as well as in your summary of the case. So that is what is to be done. It depends on your management depends on your provisional diagnosis, isn't it?
Yes, sir.
Okay. So it was a very good presentation. You've almost covered all the history and proper examination point. Let us now go in detail to the discussion about the gestational diabetes mellitus. So can you define what is gestational diabetes mellitus?
Gestational diabetes mellitus is a carbohydrate intolerance of variable severity with onset during the present pregnancy.
Yeah, you're right. There is carbohydrate intolerance of variable severity with first recognition during pregnancy or the onset with pregnancy. So onset with pregnancy is the true GDM, and this returns back to normal after delivery, whereas the first recognition during pregnancy could be a pre-gestational diabetes. Okay, so you'll have to say as over diabetes mellitus and GDM. In GDM, first recognition during pregnancy and onset with pregnancy. Onset with pregnancy is true GDM, and the blood sugars return back to normal after delivery. Okay. Okay. Now, what are the effect of GDM on pregnancy.
So the maternal complications that are present during pregnancy are they can be increased.
Not the complication. This you have GDM, right, in the present pregnancy. What is the effect of GDM on pregnancy? In the first trimester, does anything happen?
Yes, ma'am. There can be abortions. There can be congenital anomalies.
Most often, GDMs usually occur between in the second trimester. Their appearance is second trimester, so there's not much of a problem in the first trimester. But if the hemoglobin, as I said, first recognition during pregnancy could also be GDM by definition. So in such cases, if the hemoglobin A1C is more than 10, they are more prone to develop congenital anomalies. Can you mention some of the congenital anomalies?
So in CVS, there is a ventricular septal defects, a transposition of great arteries, then atrial septal defects, then patent ductus arteriosus. CNS, there can be microcephaly, anencephaly, and neural tube defects, such as meningocephaly.
Yeah.
Then caudal agenesis, sacral agenesis, then there can be renal agenesis.
Very specific to GDM, what can happen is the cauda equina syndrome. Very specific to GDM is cauda equina syndrome. All other congenital anomalies which you have mentioned, they're more common in patients with over diabetes. Okay. Second trimester, effect of GDM on pregnancy.
They can have asymptomatic bacteriuria, candidiasis.
Yes.
Then recurrent UTI, then pyelonephritis.
Also can be affected if it occurs in the second trimester. Third trimester effect of GDM, it can result in macrosomia, it can result in hydramnios, or there could even be an unexplained intrauterine fetal death.
Yes.
Okay. Can you enumerate causes, risk factors for GDM?
Risk factors for GDM.
India is a country.
Yes.
So first the low risk.
Ma'am, low risk when obese patients, then
low risk is when the age is less than 25, normal weight, no family history, no abnormal glucose metabolism. So moderate risk. You mentioned the moderate risk, and India falls into the moderate risk group.
Yes. So positive family history of diabetes. Then there is a
overweight before pregnancy.
Yes.
Or after 25 years.
History of previous
first degree relatives.
Yes.
Ethnicity, that is Hispanic, African, Southeast Asian women are more prone for development. These are the risk factors, moderate risk factors for the development of GDM. High risk factors are
previous birth of overweight baby of more than 4 kgs, then previous stillbirth or any patient with previous baby of congenital malformations or any unexplained intrauterine death of stillbirth.
Age more than 35 years, marked obesity where the BMI is more than 30, strong family history of diabetes, past history of GDM, repeated glycosuria during the present pregnancy, past history of a macrosomia of more than 4 kgs is all high risk cases where you need not do. I stress once again, low risk, you have to do selective screening. Moderate risk, where India is a moderate risk, you have to do the universal screening. And in those patients where it is high risk, you directly have to go ahead and do the diagnostic test like OGTT instead of doing the screening test, then going ahead with GTT. Okay. So screening for GTT the first trimester is, as you already mentioned, hemoglobin A1C should be below 6 gram %. FBS should be kept below 92 milligram, and the RBS should be less than 200 milligram. If any of these values are more, then you can diagnose either an over diabetes or a GDM. Okay. What is the importance of hemoglobin A1C? Can you tell me?
So HbA1c is more than 6.5 in the first trimester, in the first visit, then we can confirm it's a case of over diabetes mellitus and start on insulin directly. So, and monitoring for in such patients, monitoring for congenital anomalies and increase the folic acid supplementation also should be done in these patients. So 5 milligrams.
By definition of what you said, it still is GDM with first recognition during pregnancy, right?
Yes, ma'am.
Okay, go ahead. So it only tells you hemoglobin A1C estimation in the first trimester will give you an average blood sugar for the past 3 months. Whereas if you do it in the second and third trimester, What does it indicate? Why are you doing it in the second and third trimester? First trimester, it will give you an average to find
Yes,
out whether you got over diabetes or pre-gestational diabetes. You're right.
yes, sir.
But
In
why
second and third trimester,
second and third trimester?
to check to let us know whether her control of blood sugar levels were in control or not during her pregnancy.
If the patient is an oral hypoglycemic, more so on insulin, whether there is a proper control during the present pregnancy. Okay?
Okay.
Okay. So if the hemoglobin A1C is more than 10, what does it tell you?
It was not her sugar levels are not under control.
So it indicates that there is a high risk of congenital anomalies in the fetus, and also there is an early growth delay. These are two things which you must think of. It could be an early growth delay, or there is increased incidence of congenital anomalies. Okay. So many a time we used to say that if it is more than 10, you have to do a medical termination of pregnancy. With the present day investigative modalities being available, you cannot advise the lady to undergo MTP, whereas you explain and counsel the patient about if it is more than 10, the congenital anomalies is as high as 18 to 26% in the fetus. Okay, so you counsel them regarding congenital anomalies, but you do not advise her about the MTP. Okay.
Okay.
What is the growth pattern in GDM? We said it may affect the growth, isn't it?
Yes, sir.
So in GDM, it pattern affected is both hyperplasia as well as hypertrophy.
Yes.
So that means it is in the second trimester, both hyperplasia and hypertrophy are being affected. So mention internal complications and all this.
Ma'am, I couldn't understand. Mention some.
Complications of GDM.
The maternal complications can be there's increased risk of abortion. There can be polyhydramnios. There can be associated with preeclampsia. There can be preterm labor because of asymptomatic bacteriuria and recurrent urea infections.
You
And
go.
there can be
Yeah. Okay.
and there is ketoacidosis and hypoglycemia also seen during pregnancy. Then intrapartum, there is due to macrosomia, there can be increased risk of operative morbidity. Then there is shoulder dystocia can also be seen. Then postpartum hemorrhage because can be seen in the intrapartum period because of polyhydramnios. Then there can be prolonged labor. In postpartum period, there can be purpura sepsis.
Good. Very good. You have enumerated almost all the cause, but let us go in detail one by one. Okay. Whenever we see the maternal complications, you divide these into antenatal and intranatal complications. Okay. Antenatal complications they are more prone for the development of gestational hypertension or PD. Isn't it? 25% of these GDM patients are more prone to develop what? 30% of the preeclamptic patients are more prone for the development of diabetes mellitus. So PE is more common in women with diabetic vasculopathy or nephropathy. The next common fetal polyhydramnios. Why does polyhydramnios occurs? This occurs in 30% of the patients.
Polyhydramnios can occur because of fetal polyuria due to fetal hyperglycemia, or there's chronic irritation if there's glycosuria present in there's amniotic irritation, and this causes increased amniotic fluid. Then there can be large placentals also. There's fetal anomalies such as esophageal tracheoesophageal fistula or esophageal atresia. That this can lead to polyhydramnios.
Yeah, maternal hyperglycemia leads on to fetal hyperglycemia, and this in turn produces hyperinsulinemia. That is the main cause. Then fetal polyuria because of the irritation of the amniotic membranes and amniotic glucose production also, which may also be responsible. And most important, it could be associated neural tube defects. So any of these could be the cause for development of polyhydramnios, which occurs in 30% of the cases of GDM. Then next common complication maternal antenatally is the preterm labor.
Yes.
Why does labor occur?
Preterm labor can occur because of polyhydramnios and premature rupture of membrane. Or she is prone for recurrent infections. These infections can lead to preterm delivery.
Polyhydramnios and ascending infection with resultant chorioamnionitis in cases where there is PPROM are the major risk factors for the development of preterm labor. And maybe it could also be due to what? Iatrogen.
Iatrogen,
if there is a fetal growth restriction, as in case of vasculopathy or in case of nephropathy, you induce labor earlier, or there is worsening nephropathy, or it is also indicated in GDM with complications of. So it could be iatrogenic where we are inducing labor because of complications. Okay. Otherwise, two causes of polyhydramnios are ascending infection. Okay. Next is other vaginal candidiasis, and as you said, urinary tract infection. Asymptomatic bacteria is the main cause, and this may be because of the poor glycemic control in the. It could also be because of complication could be big, which may occur is hypoglycemic attacks, and this is more common in patients who are on insulin, especially early morning hypoglycemia is very common. Then ketoacidosis occurs. The main cause is because of the lack of insulin. This lack of insulin increased glucose production. So this increased glucose production results in diuresis, dehydration, and electrolyte loss. Or the second cause could be there is increased lipolysis with increase in the free fatty acid level. So this increases the ketone body production. These are the two main pathways where ketoacidosis occurs. And of course, other precipitating factors for ketoacidosis is the poor compliance, infections, and unrecognized new onset of diabetes could also be the cause of ketoacidosis. And other specific factors during pregnancy would like to highlight is hyperemesis gravidatum, which worsens. And when you're treating the patient, beta mimetics as tocilizumab preterm labor, and also where you use corticosteroids for lung maturity, factors which precipitate ketoacidosis. Okay, what are the patients?
What are the
Other told you maternal classify into antenatal as intranatal classification. So what we talk PE, gestational hypertension, preeclampsia, ketoacidosis, infections, preterm labor are all antenatal complications.
Yes, sir.
Tell me the intranatal complication. That means during delivery.
No, yes, sir. So there can be the macrosomia, this one is macrosomia, so there can be operative increased operative mobility, then there can be shoulder dystocia. There can be PPH in the internet.
Because of macrosomia, shoulder dystocia, because of macrosomia. So soft tissue injuries, cervical tear, vaginal of episiotomy, third stage of labor because of over distension of the uterus. It could be an atonic or a traumatic PPH, increased incidence of instrumental deliveries because again, big babies, and also increased incidence of cesarean section. So these are the intranatal or intra during labor complications. So we have completed the whole list. Let us go on to the fetal complications now.
So there can be again fetal complications are macrosomia, congenital anomalies in over diabetes cases. Then there can be after birth, there can be hypoglycemia, hypocalcemia, hypomagnesemia, polycythemia, and respiratory distress syndrome because of delayed lung maturity.
Yeah. First, about the anomalies, we already discussed. GDM usually manifests in second trimester. So GDM patients usually do not have increased incidence of congenital anomalies. But in over diabetes, you have already given a list. Just I will enumerate. Neural tube defects, spina bifida, anencephaly, holoprosencephaly in the first trimester. Cardiac defects like VST, tetralogy of Fallot, transposition of great vessels. Renal, it produces CDM is the caudal regression syndrome and increased incidence of abortion. So most important, as you said, is the macrosomia. Why does this occur? Why does macrosomia occur in diabetic patients?
So according to Pedersen's hypothesis, there is a maternal hyperglycemia, which stimulates the beta cells of pancreas of fetus, which are functional in the 32, which are functional in the pregnancy, and this causes hyperinsulinemia. This hyperinsulinemia in the fetus causes lipogenesis, glycogen synthesis, and protein synthesis in the baby. That leads to fat deposition and leading to macrosomia.
The main causes are, one is excessive deposition of the fat on the shoulders and trunk, and this is because of, as you said, Pedersen's hypothesis. Maternal hyperglycemia results in fetal hyperplasia and hypertrophy of the beta cells of Langerhans. This again increases the secretion of fetal insulin. So fetal insulin produces more carbohydrate utilization and accumulation of fat on the shoulders and in the trunk, resulting in macrosomia. And also like insulin, like growth factors also act upon to produce macrosomia. Leptin and maternal obesity are also contributing factors. So there are two theories which contribute for this. One is the Patterson's hypothesis. The other is also the Barker's hypothesis. That is, the origin of chronic disease of adult life lies in the intrauterine environment. If this baby was born for the GDM mothers in the intrauterine life, when they're exposed to high blood sugars, they're more prone for the development of GDM. So both the Barker's hypothesis as well as Patterson's hypothesis also contribute for this. And other causes are, it is also due to the free fatty acid, which are transferred to the fetus because of the increased fetal triglyceride levels. And except for the brain, most of the fetal organs are affected in cases of GDM. And how does it differ from LGA fetus? That is large for gestational age. You also have something called large for gestational age, isn't it?
Yes, ma'am.
Elavarsan?
No, I don't know.
Yeah, anthropometrically, when you measure the AC is very large is more in case of large for gestational age. And because in macrosomia, there's a uniform accumulation of fat, it is not so much. But AC is a main indicator for development of macrosomia. If it is more than the 90th centile, it indicates they're more prone for the development of macrosomia. The fetal could result in fetal distress, or as we said, there can be sudden IUD. The causes for IUD are, it could be because of ketoacidosis, because of hypoglycemia, hypoxia, poor glycemic control, and associated preeclampsia. So both hyperglycemia as well as hypoglycemia, both are dangerous. Both extremes are dangerous. It can result in intrauterine fetal death. So during delivery, as you said, it can result in birth injuries because of big baby and shoulder dystocia, hypoglycemia, hypocalcemia, hypothermia, hyperbilirubinemia, polycythemia, respiratory distress syndrome, and also increased incidence of perinatal mortality. So these are, I've enumerated all the fetal complications of GDM. So what can happen in the adult life? Do you expect anything to happen, or it stops at delivery?
After an adult life, they can develop obesity, and they also are a high risk of getting diabetes mellitus,
Very good.
developing diabetes.
There is a risk of 1 to 3% of developing diabetes later in lifetime too. And this incidence is much more even if the father is diabetic, and is also increased incidence of obesity and metabolic syndrome during the adult life. So long-term monitoring of patients of GDM are also indicated. So you have to detect these complications at the earliest and treat. So now we have finished the etiology, the maternal and the fetal complications of GDM. Now we have made a diagnosis. Screening test we covered. One-step test, two-step test, GTT indications we have already covered. We won't discuss it once again. So having made a diagnosis, how will you manage a case of GDM? What are the aims and objectives, and how do you manage?
So we first start the patient on medical nutritional therapy, and then we put her on medical nutritional therapy for 2 weeks and check if she is bringing the glucose levels on control. If it's not under control, then we started on oral glycemic drugs or insulin. But if the patient comes in for the first trimester with increased glucose levels, then we start directly on insulin.
So
Then
principles of management is, one is the preconceptional advice to the patient, antenatal glycemic control, prevent complications by proper management, and also the obstetric management. Preconceptional care is if the patients where BMI is more than 30 or who are obese, you ask them to have an acceptable weight before they embark upon pregnancy. That is the proper advice you have to give. And antenatal care in JDM women. How frequently should you see them? Is it a low risk or a high risk case?
it's a high risk case. So in JDM, we need to ask them to, after 32 weeks, we need to ask them to come by 2 weekly once. And after 32 weeks, we ask them to come weekly once.
Correct. It is when once you diagnose GDM, from that moment, you put her into the high risk category. So more frequent antenatal visit with regular sugar profiles and strict control of sugar forms the mainstay of treatment of GDM patients. Also, early recognition of complication like any infections, UTI, asymptomatic bacteriuria, ketoacidosis, preeclampsia, and fetal well-being test, you start as early as 30 weeks, and you have to plan the delivery much in advance. So the treatment option, as you said, would be your MNT, oral hypoglycemics, or insulin, that is pharmacotherapy. So first thing by default would be your diet and exercise. That is,
Yes.
if your DIPSI test is more than 140 up to 200 milligram, you put the patient on medical nutritional therapy or MNT. That means you have to have diet and lifestyle modification, which form the main cornerstone in the therapy of GDM. Okay. So for medical, you will have to give them 3 meals, 3 snacks, 3 hours interval. You remember that it is very easy. Principle of three, that is 3 meals, 3 snacks, and in between it has to be a 3 hour interval. Okay. And it
Okay.
should have 35 kilocalories for low BMI, 30 kilocalories for normal BMI, the caloric requirement, 25 kilocalories for the high BMI patient. And in this, carbohydrate should be 35 to 45%, proteins around 30%, fats 30%. And the diet should include adequate fibers also. If this cannot be followed for the rural woman, you can explain the plate method. So 1/4 of the plate should have carbohydrate, 1/4 of the plate should have protein, the remaining half should consist of vegetables. So either you can explain this or that, but the important thing is 3 meal, 3 snack, and a 3 hour interval between each meal or a snack. And moderate exercise of 15 minutes after each breakfast, lunch, and dinner is indicated, so that you have a target glucose levels in MNT. You maintain it with a fasting level of 95 milligram, a 2-hour ppbs of 140, and 1 hour ppbs of 140 milligram per percent. So this is the target blood sugar which you have to maintain. So what are the indications where you have to start pharmacotherapy? You have started the patient on MNT. How long will you be, and what will you do? Is the next question for you, elavarsan.
If the patient is started on MNT, and for after 2 weeks, we check a fasting blood sugar and 2 hourly ppbs. If a fasting blood sugar is more than 95 or a 2 hourly ppbs is more than 120, we can start her on insulin.
Yes. There are two schools of thought in this. Pharmacotherapy is indicated. Okay.
Okay.
If your 2 hour ppbs is more than 120, if 1 hour ppbs is more than 140, if the fasting is more than 90, but we usually stick on to 2 hour ppbs, which should be more than 120. Okay. If that is more than 120, you have to start pharmacotherapy for the patient.
Okay.
If it is less than that, you continue with the MNT and manage the case properly. Okay. You continue with it. So pharmacotherapy is indicated in case that ACOG and ADA criteria, as you already told, is FBS more than 95, 2-hour ppbs more than 120, and 1 hour ppbs more than 140. And in old classification, that is Priscilla White classification A2. You know the Priscilla White classification?
No, I don't know.
But it falls into A2, where the FBS is more than 105 milligram per deciliter, or if any value is more than 200 milligram, pharmacotherapy is indicated. Okay. So there are schools of thought here. I will just make it very simple for you to understand. Diet with exercise is indicated if FBS is less than 95 and ppbs is less than 200. So diet alone with exercise is sufficient if these two values are there. Diet, exercise, and metformin are indicated if the FBS is more than 95 and the ppbs is between 140 and 200 milligram. Then diet, exercise, metformin, and or insulin in those patients where the blood sugar are uncontrolled with metformin, or if the FBS is more than 125 milligram or the 2-hour ppbs is more than 200 milligram. There are two schools of thought. Insulin is thought to be the first line of treatment for GDM patients, but the Government of India guidelines recommend that only insulin should be given before 20 weeks of gestation. You have to start only on insulin. And it's recommended if the FBS is more than 110 milligram per deciliter. And if pharmacotherapy is required in the third trimester, you straight away start the patient on insulin. These are the indicators for insulin. Now we go to the oral hypoglycemic drugs, that is sulfonylureas. The drug of choice, what we use in GDM is one is metformin, the other one is glibenclamide. These are the FDA approved, used in pregnancy. Tell me something about metformin.
Metformin, the patient is started on metformin usually 500 milligrams per day. that twice BD, 500 milligrams BD, and maximum it can go up to 2 grams per day. But the side effects here are nausea, vomiting, and there's increased risk of lactic acidosis in these patients.
Correct. So dosages, you start with 500 milligram in the morning. Okay. And if it is not controlled with a single dose, you increase another 500 milligram in the evening. So any increase should be in the increments about 500 milligram. And as you said correctly, the maximum dose of metformin is 2000 milligram. Actually, there are no serious side effects. As you said, minor side effects like nausea, vomiting, bloating, metallic taste, diarrhea, and vitamin B12 deficiency have occurred. But the advantage of metformin is that it is very good for pre-pregnancy control of sugars. If the patient was already on metformin for PCOS, you continue with the metformin during pregnancy. And it also prevents abortion and GDM in the present pregnancy. There is no severe effect of hypoglycemia. It does not stimulate, importantly, the fetal pancreas, lesser incidence of macrosomia, and there is minimal secretion in the breast milk. So these are the advantages. It does not cause what?
Does not cause hypoglycemia, does not affect lactation.
There is lesser incidence of macrosomia and minimal secretion of the breast milk. So it can safely during the pregnancy. What about the glibenclamide? Any contraindication for this? Metformin use?
I don't know.
Potential state, alcoholism, severe respiratory, hepatic, and renal disease are all contraindications for the use of metformin. Now, glyburide. Glyburide, second generation sulfonylurea. The advantage is that it does not cross the placenta. There are no side effects. And where do you give?
When metformin alone is not able to control the dose, we can add.
Avoid glyburide if the FBS is more than 110, more than 30 weeks. As I said, the indication for pharmacotherapy in the third trimester would be the insulin. The choice. If the PPBS is more than 140, again after 30 weeks, you avoid giving glyburide. And also in those patients with higher weight gain or macrosomia, so you should avoid giving glyburide. Better is metformin. Okay. So what are the indications? Put the patient on oral hypoglycemic. What are the indications for you to admit the patient?
Poor glucose control.
Very good.
Then any other associated complications like preeclampsia is present?
Is mainly to start the insulin therapy if it is not controlled with oral hypoglycemics, and also to manage any complication. As you said, it could be preeclampsia, it could be ketoacidosis or severe polyhydramnios. And 37 completed weeks, you have to hospitalize the patient to deliver her. Whichever the route of method depends on the case. So you have to admit. These are the indications for admission for insulin therapy to manage the complications like polyhydramnios, macrosomia, or ketoacidosis, and also if there is development of PE and when she has completed 37 so gestation. So now when will you start insulin and what are the types of insulin you know of, elavarsan?
Insulin is started if the patient is diagnosed with JDM in the third trimester, or if she is above or two, if she are any two or PBBS comes more than 200 milligrams per deciliter. So insulin, we give a mixture of 70% of intermediate acting insulin and 30% of short acting insulin, which is premix insulin.
Yeah.
And
the women on metformin require insulin. Remember that. They're not just controlled with metformin alone. 30% of the women who are on metformin require insulin. Okay. And the dosage trimester is 0 units per kg per day. Second trimester, it is 0.8. Third trimester is 0.9 kilocalories. And a term, it's 1 unit per kg per day. But if you calculate per body weight, the insulin requirements becomes very, very high. So ideal is to start with regular insulin, 4 or 6 units, 3 doses, 4 units per day or 6 units, 4, 4, 4 or 6, 6, 6 of regular insulin, and thereby you manage, you control the sugars properly. That would be ideal because if you calculate by the requirement of the insulin in the first, second and third trimester, the calculation becomes very much. If she is around 60 kgs, you will require 60 units a term. That will be very high dosage. So it is ideal initially to start with regular insulin, 3 doses, 666 units, and then you monitor the blood sugars. Okay.
Okay.
In 32 weeks, the insulin requirement physiologically increases 50%. So you have to be careful during that stage, that is between 20 and 32 weeks. The requirement of increases, thereafter it falls. Okay. So you maintain 666 units regular insulin until you get the target control. When once the target control is there, you change it over to mixed start combination, that is 30, and you give the morning and evening dose, 2 dose. And why dose?
Ma'am, because to avoid midnight rise of glucose levels, ma'am, in the
And it also matches with that of the physiological endogenous production of insulin. What you as the 2 peaks which occurs physiologically, it matches what that 2 peaks, and so that is why you give this 2 doses of insulin and in the evening. Okay, so it's the physiological endogenous release of insulin. So 2/3 of the regular dose what you calculate should be given in the morning, and 1/3 of the dose should be given in the evening. Normally, short acting and intermediate acting is ideal. You can give insulin, and even insulin analogs can also be. Insulin analogs are Lispro, Aspart, but they are very expensive and hence we are not using it. But otherwise, analogs can also be used because there is immediate action and the complications are very less with rapid acting insulin analogs, but they can also be used. So we have now started with the diet, exercise, oral hypoglycemic, pharmacotherapy, common or right, and insulin. Now, what is the obstetric management of patients with GDM?
so
How will you monitor?
so we after 32 weeks we start NST every bi-weekly, and biophysical profile is done every week for the fetal monitoring. Then we can ask the patient to for daily fetal count.
Hmm. So,
Daily fetal.
start anytime after 30 weeks, right?
Yes, ma'am.
And then,
So daily fetal kick count also is important.
okay, when you admit the patient, at what gestational age would you like to admit the patient?
Ma'am, if she's a known case of GDM along with IUGR and or any other complications, then we admit her at 36 weeks and induce the patient and deliver before 37 weeks. But if she's a known case of GDM and on insulin or over diabetes, then we admit her by 38 weeks and deliver the baby. And if she's on MNT up to MNT and was well controlled, then we can wait till 40 weeks for delivery.
Okay. So, a comment about the ultrasound in GDM patients. What are all the timing where you do and what are the ultrasounds you do? You mentioned
So
scan,
some ratings
first trimester, then NT scan at 12,
10 to 30.
correct? Early anomaly scan, 14 to 16 weeks, scan, 20
At
weeks,
18 to 20.
correct? Then the growth scan and the term scan. Okay.
So,
And Doppler is indicated only if there is a vasculopathy or a nephropathy, like GR in patients. That is in Priscilla White classification, not in regular GDM.
yes.
Do you do 2D echo?
No, ma'am, we don't do routine 2D echo.
GDM patients?
In
Fetal,
GDM patients, we are supposed to do fetal echo at 22 to 24 weeks, ma'am.
yeah, it's not necessary that you have to routinely do fetal echo in patients with GDM. Okay, it's not necessary. Only in those patients where the mother has got heart disease, in women with overt diabetes, or if you're suspecting a trisomy, these are the indications where a fetal echo is indicated. Normally, as a routine, fetal echo is not indicated in all patients. Okay.
Yes. Okay.
And as you said, at 39, if the patient is under MNT, good control. At 39 weeks, you admit the patient because to say that RDS is at the least whenever you do the delivery at 39 weeks. So GDM and well controlled 39 weeks. If the patient is on insulin, as you said, at 38 weeks, you'll have to admit the patient and terminate. GDM with complication of T, then you'll have to admit the patient at 37 weeks, completed weeks, and terminate. Can you do induction of labor?
Yes, some induction of labor can be done.
Yeah. Contraindicated in such patients. You can do induction of labor either by using the Cerviprime gel or with a Foley's catheter, because you're not waiting for spontaneous onset of labor at 30. If it occurs, fine. If it does not, then there's no contraindication for induction of labor. What are the indications for LSCS then?
From here, microsomia.
Yes, correct.
And cephalopelvic disproportion CPD. Then other obstetric complications, the preeclampsia is present. If she has a bad obstetric history, elderly primary gravida, and poor diabetes control, we prefer LSCS.
The main two indications specific to your GDP, one is macrosomia, the other one is a fetal compromise, fetal distress. All other indications, as you said, the advancing maternal age, previous LSCS, CPD, placenta previa, fetal distress, malpresentation, or all other obstetric causes. So far as GDM is concerned, there are two indications. One is a fetal compromise, the other one is macrosomia. Okay?
Okay.
Manage during labor. Okay, so now that we've induced labor, she has sit into labor now. She's not. Yes. So how do you?
Ma'am, so you ask her not to have breakfast and you don't give the morning insulin dose.
You skip the morning glycemics. Okay.
Then
Main objective during labor is you maintain the glucose between 72 to 1. According to AC guidelines, you will have to maintain 72 and 126. Give adequate hydration to the patient, and proper calorie intake should be given during labor. Continuous with CTG has to be done. And in all cases, anticipate shoulder dystocia, because macrosomia by Western standards is more than 4 kg. For Indian standard, it could still be less. So the main thing to anticipate macrosomia is your single measurement of AC in your ultrasound. So anticipate shoulder dystocia, anticipate postpartum hemorrhage, either traumatic or atonic, and follow active management third stage of labor. Okay. And what about do you do early cord clamping or delayed cord clamping?
we should do delayed.
Early clamping should be done in patients with macrosomia. Remember, this is in order to prevent polycythemia and hyperbilirubinemia in the fetus. Early cord clamping in macrosomia is the dictum. This is done in order to prevent polycythemia as well as hyperbilirubinemia. Okay? And you will have to put 5% dextrose with 10 units of insulin, or dextrosaline with 6 units of insulin, and check hourly the blood glucose. And you also have to check for urine ketone bodies as well as serum electrolytes when the patient is laboring. Okay?
Okay.
Good. Now you have managed. What about the post-delivery management?
Ma'am, post delivery, we monitor for her glucose levels after 6 weeks, ma'am.
No. Immediately after delivery, the patient has to be monitored GRBS second hourly or fourth hourly, accordingly by the sliding method. Look for all signs of hypoglycemia. Cover the patient with antibiotics. Early breastfeeding is the dictum of choice. As early as the baby is born, you put her to the mother's chest, or within half an hour, you'll have to start. And feeding should be continued every hour in order to prevent hypoglycemia in the baby. And this breastfeeding is very, very important in diabetic patient. It has certain advantages to the mother also. It helps in reducing the maternal weight loss. It improves the fasting blood glucose level and also the glucose tolerance. It also increases the lipid, which is triglyceride levels. So what do you do later?
So
most of the patients who are on oral hypoglycemia or on lower doses of insulin do not require any treatment in the postpartum period. But however, as we said, monitoring of the glucose is important. If they are more, you check the SBS and M.B.B.S and you start them on oral hypoglycemics or on insulin, depending on the blood sugars. Most of them do not require any insulin or hypoglycemics in the postpartum period. True GDM. Okay?
Okay.
Then what do you do? What do you advise her? We have to discharge the patient. What is it you want to advise the patient? Exclusive contraception advice, all that is okay. Anything specific for the GDM patients you advise?
Ma'am, we ask her to check her glucose levels every early once and do a OGTT test.
OGTT is indicated after you ask her to take the OGTT test after 6 weeks. But ACO guidelines mention that patient has to undergo hemoglobin A1C estimation after 6 weeks. So either
Okay.
or OGTT, the patient must undergo and tell us the result. So you have to give a follow-up of the patient after 6 weeks to do this test.
Okay.
And you also, if that is negative, then you follow up these patients every yearly with the hemoglobin A1C estimation. If it is normal.
Okay.
That is because you have to explain the long-term effects. As we said, 1 to 3 of them may develop obesity or metabolic syndrome, right?
Yes,
So
sir.
to prevent that, you should have a long-term management. Okay.
Okay.
Most of the points of screening tests and the management, diet, exercise, oral hypoglycemics, and insulin. I think we have covered everything. You have done a good job, elavarsan. You have done a good job in the history taking and in examination. Any doubts? Anything? Otherwise, we conclude the session.
Ma'am,
No, ma'am, no doubts.
anyone who has doubts can enter into chat box. Right now, we don't have any questions, ma'am. So before we conclude, I would like to extend a heartfelt thank to you, our mentor, Dr. Rupakala ma'am. Your expertise, insights, and guidance have been invaluable in helping us understand the complexities of gestational diabetes mellitus. We are deeply grateful for the time and effort you have invested in guiding us through this presentation. Thank you for your unwavering support and for always inspiring us to achieve excellence. Thank you, ma'am.
Thank you for your kind words. Thank you, elavarsan, for a good presentation. Thank you.
Thank you.
Thank you, everyone.